So welcome to our MOG project support group. I am Dawn Groves. This is my husband, Brian. We have a 10-year-old daughter diagnosed with MOGAD 3 years ago. And we've been leading a support group for a couple of years with the MOG project. But we're not here about us. We are here because Dr. Lana Harder is with us today, and she is on staff at Children's Health in Dallas, Texas. She's a neuropsychologist. We're so excited that she's here. Brian and I actually had the opportunity to meet her this summer when we went to San Antonio for the SRNA's family camp, which was amazing, and something that I think that we can't recommend any more than, like, we just highly recommend it. It was life-changing for our family, and especially our daughter who has the disease. So Lana Harder was nice enough to agree to come on and share all of her wisdom and knowledge with all of us. And so we're going to record just this first part. She has a presentation that she's going to show us first. So we're going to record that part. And then once we open it up to Q&A, we're going to stop the recording because we want you to have a chance to ask any questions without feeling like people are going to hear it all over the world. So, Lana, thank you.
Thanks so much for the introduction. It was great meeting you at camp and many others, and I can't recommend camp highly enough. I learned so much about these conditions just from having a more leisurely time with kids and families that I don't necessarily have in the same way at our clinic. So camp is amazing. Let me share my screen just to get us going here. Hopefully everybody can see that. So I'm here tonight to talk about pediatric neuropsychology, what we are learning about this as it relates to MOGAD. And I just want to thank you so much for this invitation. It's a privilege to be here. And as I said, I learned so much from getting to connect with our patients and families and those who know what it's like to experience these rare conditions that we treat in Dallas. So with that, I just want to give you a little bit of context here for the work that we've done in this area. So as we said, we're at a clinic at Children's Health in Dallas. Back in 2009, I just had the great fortune of being, as I describe it, in the right place at the right time. I had just started a position in late 2008, straight out of my fellowship. And then UT Southwestern and Children's had recruited Ben Greenberg, our neurologist, to come open a center for both adults and kids with these rare neuroimmune conditions. And so I got to be a founding member of this program. And I guess we're going on, it seems, about 15 years now. And so neurology, so Dr. Greenberg and I in neuropsychology co-direct this clinic. And as you can see, have other specialists there with us. We are fortunate to be able to take a team approach to have this one-stop shop for patients and families. And you can see the all of the areas represented: nursing, social work, school services. We have someone who does our vision testing there, physical medicine and rehab, and a whole host of other specialists that are kind of on call that we bring in as needed. So it's a really been a great experience for us as clinicians to all come together every Friday to serve patients with these conditions. And I actually wanted to show you the sort of the spectrum of conditions that we work with at the clinic. So these are all known as central nervous system demyelinating disorders. And I'll be highlighting where MOGAD fits into all of this a little bit later. But multiple sclerosis is one of the conditions, and this is separate from MOGAD as far as we know at this time. We have been given the designation of a National MS Society comprehensive care clinic for the multidisciplinary approach that we take, which has been really excited. Another partner of ours is SRNA, we were just talking about. that puts on the camp. A lot of our team members go to that camp. It's how we get to connect with folks that are outside of our Dallas clinic, which is really exciting for us. I had to share this photo. We have a lot of fun in our clinic, as you can see. We don't dress this way every single week, but we are there on Fridays. And when it coincides with Halloween, like it did this particular year, we have a lot of fun with that. So wanted to share a little bit about our program. And then to sort of narrow and focus a little bit on neuropsychology, I realize not everyone has encountered neuropsychology or knows what we do, but kind of this simple high level definition is we're looking at human behavior as it relates to functioning of the central nervous system. And I'm going to elaborate that on more tonight, but a big thing that we're known for is assessing all of these areas that you see on this slide. So cognitive functions like memory, attention, how fast we think. Also, we look at behavior, emotions, quality of life. And I think importantly for this topic, fatigue is another thing we look at as well. So we really want to understand how a medical problem might show up in daily life for someone. We know that the impact of a given condition can really differ across people. So we just want to understand that for the individuals we serve. So in our clinic, a big emphasis and where it all started was the clinical care piece. So I am there as a consultant to my team members, but also, of course, to the patients and families we work with. We also do a formal screening evaluation, and I'm really going to elaborate on that this evening. And then for those who come to clinic and do this screener or a consultation, and we feel that a full neuropsychological evaluation is needed, then we would refer them on for that. And that is an evaluation that takes most of a day. We say, think of it like a school day. You're going to come hang out with us starting in the morning until late afternoon. We'll take a lunch break, but we're really evaluating a kiddo across the entire day. And then we have a whole focus in our clinic on transition planning, and that's transition to adulthood. We want to make sure that the kids that we work with are positioned to kind of take the reins or evaluate what the patient and family need to make the transition, whatever that looks like for them. In addition, I mentioned I co-direct the clinic with Dr. Greenberg, but we really believe in educating and training our next generation to know what these conditions are. If you're familiar with SRNA's fellowship program, we've trained a lot of physicians in this space, and they have they're disseminated throughout the country. And so that is really a big part of our goal. Same thing happens for me with my neuropsychology trainees, interns, and fellows. So I've had a number of students do dissertation projects on these conditions. So that's been really exciting. So research is also a big part of what we do. And on that note, I wanted to say that as a neuropsychologist, I come to different conversations and presentations, recognizing that the role is really different if I am evaluating one person in front of me. That's a tailored evaluation looking at, as I said before, how a medical problem shows up for them in daily life. And we design a test battery just for them and just for the questions that we have for what's going on. For instance, someone might want to know, does my child have ADHD? Do they have dyslexia? Whatever those questions are, we really want to be sure we answer those through our evaluation. When it comes to research, I'm really looking outside the individual. I'm looking at a group of kids that have something in common. In this case, it's MOGAD, and that's what the data I'm going to share with you tonight. So often it's a diagnostic group like MOGAD. We might have a specific age range we're focusing on. For me, this is pediatrics, and that range is pretty big. And then we may have hypotheses in our research that we're testing out. So, depending on what hat I'm wearing, I might be thinking about the information in front of me a little bit differently. So again, setting more context for this conversation and what we're understanding and learning about demyelinating disorders. So broadly, we know that these conditions are autoimmune. There's an attack to the central nervous system by the body's own immune system. What Dr. Greenberg will frequently talk to our kids about is, you know, the immune system is confused and it's going after something that is actually really important, right, for our functioning. And so as you can see in this animation, the myelin is what is damaged in the process. When it comes to MOG specifically, we know that MOG is a glycoprotein that's important for that myelination, right? And so that that is a factor, and that is actually an advance we've made in the field to identify this anti-MOG antibody, that now we have a target as we think about treatments, you know, going forward, and things like that. So we can understand MOG in ways we have not understood other demyelinating disorders that we've worked with. You all may know, I'm assuming this is a very savvy group that knows a lot about this condition and will probably teach me some things tonight. MOGAD, we know, is more common in kids, and the most common syndrome associated with anti-MOG antibody is our acute disseminated encephalomyelitis, or ADEM. And that seems to be the largest group when they look at research data. That's going to also be the case for the data I share with you tonight. And then, of course, our clinical presentation will depend on the target of the attack. So I showed you this earlier to give you a sense of what we see in our clinic. And as you can see here, a lot of these conditions that we work with can be associated with MOG or MOGAD. So when kids are coming through our clinic now, it's very standard to have testing for this. When I started in the clinic, we had never heard of this, right? This was not on our radar at all. And so one thing I find very exciting about this field is we're making scientific discoveries all the time. And then we can use that information to inform the research that we're doing, right? That we can say, okay, well, let's now look at all the kids who tested positive for MOGAD and describe them, look at how they do on neuropsychological measures. So it's an exciting time, I think, to be learning just a lot more. At this time, very little is known about neuropsychological outcomes of pediatric MOGAD, as you all probably know. And so it's really our challenge to hustle and pull our information together, get it out into the world, publish it. And that's exactly what's happening right now. So I'm giving you a little bit of a preview of something that we're putting out as a team, the Dallas team, and hopefully, fingers crossed, it will be published. So if so, it will be the largest cohort of MOGAD patients looking at neuropsych functioning that would be out there. So this number here, I'm going to show you the data that we have, and that I'll kind of break down for you. We had 38 participants. This number has increased. We've just updated the database right before we submit for publication. So we're at 45 now. So this number has gone up, which is really exciting. Our age range is very broad. Again, that pediatric range, 5 to 19 years old, but the average age for the group was 11 years old. Most were female at 66%. And then you can see the race and ethnicity distribution. So 60% white, 26% Black or African American, 11% Asian, 3% other or unknown. And then 16% of our patients in this cohort were Hispanic or Latino. There, as I mentioned earlier, 60% have ADEM. That was their clinical presentation. And then the next largest group was 18% with bilateral optic neuritis, 11% optic neuritis, 8% transverse myelitis, and then 3% with optic neuritis and TM combined. So just to give you a sense, I know when I'm trying to explain what neuropsych is, sometimes people picture medical procedures or, you know, all kinds of things. We're really non-medical doctors. So I always say that right away. I'm Dr. Harder, but I'm not a medical doctor. And that can be a relief to the patients I'm seeing. So we don't do any medical procedures. Instead, the assessments we're doing are more, as you see in the picture, paper, pencil, question, answer, looking at pictures. We have some computerized measures we're using these days. So it's really, that kind of one-on-one assessment of a whole range of different skills. And on the note of that, these were the areas that we evaluated. So in our clinic, again, we do a screener for everybody that comes through, because we know for demyelinating disorders, broadly speaking, kids can be at risk for cognitive difficulties. Processing speed is one that can be highest on the list, and particularly if you're thinking about multiple sclerosis, but some of our other conditions as well. Fine motor skills tend to be vulnerable, or how well we integrate the vision and motor when we're writing or drawing, how we perceive visually. Attention and executive function. I tell my students all the time, if you're asked what cognitive impact a certain condition has, for a child, it's really safe to talk about attention and executive function, simply because those develop last. Those are the last skills to come online in the brain. And so if you're talking about kids, those are areas that might be more vulnerable than other skills, like language, that are established a bit earlier in life. And then memory is another one that we really want to look at very carefully, very closely. Of course, quality of life, mood, behavior, and school factors. So we get a lot done in that screener. It takes about an hour to do. I don't want to bore anyone with too many details here, but I just want to say that when we measure a given construct or domain in neuropsychology, we're looking at how a person compares to other people their age. So it's not arbitrary or just kind of like raw score points. We're actually comparing them against percentiles, and to see for kids, if you're an 11-year-old, okay, how do we expect 11-year-olds to perform in a given area? What you see in front of you here is a normal curve, and this 68% is the green area is representing the broad average range, is how we would describe that. So what we expect for people. And as you get below that, that's where we become interested in, is there a problem, right? We would want to zoom in on that. Now, if a score here or there goes below this point, we're not going to make too much out of a single score or a couple of scores, but if we're seeing a trend or a pattern, that's when we are going to draw some probably more significant conclusions. For the purposes of research, we decided to describe percentages that fell at this point. So what we call this here, let's see. So let's take 100 as an IQ score, has a mean of 100, and what we call a standard deviation of 15. So if you go 15 points in either direction, you're at 85 to 115, and that's the broad average range. So one standard deviation or lower, we took a snapshot of that and looked at what percent of kids fell below that point. So that was how we described the data that we saw here. So I'll say this, if we just pulled all the data together across these tests that we gave, as a group, scores mostly fell in the average range, but we saw a lot of variability. So there's a big range across the kids we evaluated. And again, we looked at the percent, how often a score fell at or below that one standard deviation. So here's what we found, kind of the broad strokes here. More than 30% showed difficulty with our fine motor coordination, so these hands-on timed tests that we gave them. Verbal learning and memory was another area, and I want to emphasize a point about this. It's not that memory was just terrible for more than 30% of the kids. Actually, the really interesting thing we saw is when we gave them a list to remember, and we read that list to them 5 different times, And we were looking for them to improve their memory with each exposure, right? If I hear a list once, I might not get that many, but if I hear it twice, I'm going to get more, and so on. What we saw was difficult for our kids with MOGAD was remembering that list that with the one exposure. But what was really great to see and encouraging to see is with more exposure, so rehearsal, repetition, we saw them really go to a more average, like right where they should be. So I really want to emphasize that kind of initial learning span is kind of what we would call that. And that gives us insights for what would help our kids. And so I'll talk about that in a moment. Other things, we found that attention was vulnerable for this group at greater than 30%, falling at that level I shared with you. So to a lesser extent, again, we're talking about hands-on visual motor, just how we coordinate paper, pencil when drawing things. Here is our attention again. So now we're talking about attention when listening. Simple and complex attention was when we were looking and writing. And working memory, which is our mental scratch pad. So it's how we hold on to information and do something with it without being able to write it down or anything like that. And then we found that speed of things, so how quickly we could process information, verbal information as well, was, at least 20% had difficulty there. We don't have an established cognitive profile for kids with MOGAD. We do in other pediatric medical groups, and I'm speaking broadly, not in demyelinating disorders. But that's just something to highlight. And I'm not sure that we ever will have that profile because there's so many differences from child to child. And not only that, there's so many different clinical presentations. So a problem can emerge based on where the condition is expressing itself in the brain. And that's going to be wide ranging for our kids. This point here, half reported receiving educational support services. That really stood out to me because that's significant. That's not a small number, and that's not something that's just by chance. So these are kids also needing and hopefully benefiting from educational support services. Excuse the dog sounds background. So some conclusions here, and I think I just spoke to this. There's really not a one-size-fits-all approach, right? Because of the individual differences. And I think that really points to why individual assessments are so important. So we're tailoring the assessment battery and the treatment recommendations, the accommodation, safer school, we're tailoring that to the person. And of course, we always, as neuropsychologists and team members, want to engage with our patients, families, educators, and other partners that we might have that are taking care of our kids. I wanted to give some examples, though. Based on their research results, but also thinking of my work with individual kids with MOGAD, we do see that educational support services can be helpful. I know we've got folks here represented from around the country, and I know there are some state-to-state differences and certainly school to school and district to district differences, but federal law, is an important reference here for thinking about our 504 accommodations or special education services. Those are federal laws that protect our kids that have conditions like MOGAD, where you see a functional impact, say in learning or cognitive function. So what does that mean? What would those services look like? I know that for our kids who struggle with attention or visual changes, seating near the front of the classroom can be really helpful for that. A reduced distraction environment for taking exams can be very helpful. We mentioned processing speed earlier, so extended time for exams can be really beneficial. So we're not changing the exam or what we're asking the child to do, but we are giving them more time to show us what they know, and I think that's really important. Note-taking assistance is another one that because I mentioned the hands-on fine motor difficulties that may be hard to keep up as we're taking information down from the teacher. So we want to give them that extra support so they can focus in on what the teacher is saying in the lecture. And then I already sort of gave this one away earlier, but that repetition or rehearsal of information when learning, it was pretty striking how beneficial that was. And like I said, this was a test with many trials and scores. And the thing that we noticed was it was that first exposure that was harder to recall information, but with repetition looked really good. So those are some examples there, some conclusions from this that I just want to highlight. And I think I've touched on these already, is our outcomes just vary widely, right? We know that there may be some problems, maybe some risk for neuropsych issues, but not everyone is affected, and not everyone is affected certainly in the same way. So I think it's important that for neuropsychologists and the folks who see kids with MOGAD in their practice, that they should have this on their radar, right? Even if we don't have a neuropsychologist handy, we can ask some questions about learning and how things are going in school, and if anyone has concerns about attention or memory. And from that, thinking about how do we tailor support services for individual needs. Of course, we need more research. We already knew that, and that is still the case. And there's some really exciting things going on nationally, where programs are kind of, now that more programs are emerging for demyelinating disorders across the country, folks are reaching out and connecting and wanting to kind of pull data together so that we can have a better understanding of these conditions. There's only so much we can learn with a smaller sample, but if we get more numbers, it makes a really big difference in terms of our the statistical power that you have as a researcher to run analyses. So I always like to touch on this if anyone is sitting, kind of in the audience and thinking, gosh, some of these things sound like they're impacting my child. I would say when determining who should be referred, I think the child is a great person to ask, the child or teen or however old they are, that person and those like family, people around them that know them the best are really in the best position to help us figure that out. The big thing we want to understand is it impacting daily life? To a degree that it's a problem. And that's where we really want to get a little bit more serious about getting that individual evaluation. So the way that the world of insurance and referrals and all of that works, we would typically need a referral from a physician in order to start the ball rolling. Excuse me. That could be a primary care physician, that could be a neurologist, or whoever is taking care of the patient. I did want to highlight, just because I know for myself and people I know, you like to know what to expect. What is this going to be like? And we did talk about what it looks like with the child, kind of that one-on-one, doing a question answer and different things for the assessment. But the big process begins with an interview, and typically that's with the parents. The child, can become involved in that depending on their age, and the clinician determines kind of what that format is. But there's usually an intake or an interview to just gather information, understand what the concerns are, what the questions are, to be sure that through testing and assessment, we're answering those questions. So then we're spending a big bulk of time on the testing itself with the patient. And then at the end of that, we're delivering the results and recommendations. So a little bit more information about that. I think reviewing any records, any assessment records, medical records is very helpful. And sometimes we'll enlist, if parents agree and sign off, give permission, we'll get teachers to also fill out questionnaires and give us their input about what they see. And then we may or may not diagnose something. I mentioned earlier ADHD, dyslexia, I mean, autism falls under our umbrella, these developmental conditions we can see in the context of a medical problem. So language disorder, we have lots of stuff on our radar as we meet any individual child that we assess. I think one of the biggest values of assessment is we identify both strengths and weaknesses. So we want to know, and we say I say this at the beginning of an evaluation, is we are human. We are made to have some things we're better at and some things that are harder for us. That's typically the way it goes. And so we want to figure out how to leverage those strengths, how to get really strategic about using strengths to address any areas that are more difficult. And then, of course, we have that tailored plan we say tailored treatment plan. That could be accommodations for school, things that might help at home, whatever that might look like. And then typically a plan for follow-up. So I like to see the kids I work with, in my clinic every 6 months to a year, we're checking in. But then for that big evaluation, we might do that annually if they're younger or there's a lot going on, or every 2 to 3 years. I really like to do it at transition points. If they're about to go to middle school or high school or thinking of transition from high school, we want to be updating evaluations. Big question I get, how do we find a neuropsychologist? And so one of my go-to recommendations is the American Board of Professional Psychology. They are responsible for certification of all psychologists in their specialty area, neuropsychology being one of those. So if you ever see ABPP after a person, like after PhD, those letters, it means that they're board certified. And not every neuropsychologist is board certified, and there are great folks who are not, but that's just one place to go. Also, pediatric hospitals especially large ones in urban settings, tend to have a neuropsych team. It's a small world in pediatric neuropsychology. So often I know not only some of the folks there, but who's probably doing this work and focusing on kids with demyelinating disorders. Referring providers hopefully have names to provide, and then if all else fails, a list from the insurance carrier. So those are just some ideas there. I want to acknowledge our patients and families impacted by rare conditions who are the reason that we're able to do the research and the work that we do. And so teach me so much all the time about this. And this is my team I also want to acknowledge in Dallas. And that is all that I have. And just some beautiful nature scenes. So thank you. Thank you so much.